Welcome, and thank you for tuning in to On the Go with CAO, a podcast by the Centers for Advanced Orthopaedics. Join us as our orthopedic specialists share their tips and advice for keeping you on the go and in the know, including the latest on how we're treating and caring for injuries and diseases of the body's bones, muscles, joints, ligaments, and tendons. We're here with over 60 offices in Virginia, Maryland, and DC to keep you active and on the go.
Hi, welcome to On the Go with CAO. My name is Dr. Matthew Levine, and I'm a sports medicine surgeon here at the Centers for Advanced Orthopaedics in the MMI division in Frederick, Maryland. And I'm here with four of my colleagues who are all sports medicine experts. To get started, let's kind of walk through how we treat patients and get everybody's different take. And we'll start down with Chris. So we're going to talk about knees today to start with. We've got an 18-year-old girl. She plays soccer and she got hurt last night. Her parents are really worried. This is what she does. It's her senior year. She wants to play in college. What are they going to expect? What should they do? How should they manage this? Because they're just concerned it's the first time she's gotten hurt.
Sure, Matt. So I mean, these are obviously anxious visits for families, with a young athlete who's hurt. And so the first thing that we do is kind of get them, what happened? Did you feel a pop? Did the knee swell? Kind of the classic questions. And then you do an exam and you see if the knee is swollen, because if there's blood in the knee, something's injured. And so I always tell the patients, if your knee is full of blood, it's either you tore your meniscus, you tore your ACL, you dislocated your patella, or you have a fracture, the last one being the least likely. And so those usually require an MRI, and then we go from there.
David, so you've gotten an x-ray. You've kind of said, all right, this isn't the end of the world, right? There's worse things in sports and in life than knee injuries, but these are big, big impacts on these kids' lives. What's the timing? Do we need the MRI tonight? If they have a big swollen knee, are you going to operate tomorrow? So how do you talk them through these next steps that we've sort of defined as possibilities?
A lot depends on a variety of factors: the history, the physical exam, the x-ray findings, and also getting to know, the patient and what their expectations are. Have they had an injury before? Patients are in pain, and these are, distressing injuries, and we want to make a quick and timely diagnosis. So if an MRI is needed and there's a suspicion of surgery, then those things should occur, typically within the first 48 to 72 hours, and a reevaluation ideally that same week. But for a lot of these things, the initial treatment is really kind of the old adage of rest and ice and compression and let things settle down. And sometimes a reevaluation within a few days when the injury isn't so acute can be very helpful and may shed greater light on what's really going on.
So let's break this down into sort of three injuries that we see with frequency. We've got patellar dislocations, meniscal injuries, and then ligament injuries. And maybe we'll focus a little more on ACL and MCL injuries, since those are the most common. And so let's break these down a little bit and walk through the course of treatment. So, Brion, you've got this young woman has come in and she's got a swollen knee, and you've gotten an MRI, and it shows a meniscus tear, and she's had a week to rest, but she still doesn't have her full motion. What's the next step? But the ACL is okay.
ACL is okay, so the next step is to sort of reassure the family that you don't have this dreaded ACL tear. It's common enough, and everyone watches enough television, that most 18-year-olds that are involved in sports know that is a big injury. The meniscus injury is also a big injury, but it doesn't seem a career ender as some of the soccer players may think. So reassuring them is the first step. Then explaining to them that it does still require surgery, because in an 18-year-old, we still want to protect their cartilage, and explain to them how the meniscus is a soft piece of cartilage that protects the cartilage that's attached to the bone.
For the folks watching it, how does that work? How does the meniscus protect the cartilage?
So just to explain to them in terms that they can sort of understand, it's a soft piece of cartilage that is a little bit of a shock absorber and provides a little bit of stability when they're twisting and cutting in their sporting activity. I don't typically go into much further detail than that. But that's typically something that everyone can understand. Okay, shock absorber, reduce some of the stress, when I'm running, jumping, twisting, and cutting. Then on the physical exam, try to discern whether or not it's a mechanical blockage, like something structurally is in the middle of the knee that won't allow range of motion, or if it's just pain inhibition. If it seems like it's a mechanical blockage in the office, we sometimes numb the knee up, put a local anesthetic in there to relieve the pain. And if they're able to get their range of motion, again, reassurance, let the family know that with some physical therapy, compression, ice, a little bit of time, we should get the swelling to go away, we can get your range of motion back, and then schedule surgery on a non-emergent basis, because we don't like to operate on hot, inflamed tissue and knees. If we numb the knee up and they don't have any pain, and the patient can't bend it all the way, and with my hands I can't get their full range of motion, then we're typically concerned that it's a meniscus injury that is blocking their range of motion. That pushes up our timeline for surgery, and I start discussing with them sort of what that timeline is, and that we're concerned that there's a meniscus injury that won't allow them to fully regain their range of motion and require surgery and repair.
I think one of the most interesting things over the last 10 years is the understanding of what meniscal root injuries are. And for our listeners, the meniscus is anchored to the bone in the front and the back of the knee, under the shin bone, the tibia. A decade ago, we really didn't understand how devastating those injuries were, and small tears at the attachment of the bone were often, especially in ACL injuries, left untreated because they were quote unquote stable. And really what I find one of the more interesting things is how we've really come to understand that those injuries are really bad, and that if you don't fix those root injuries, the young athletes get arthritis really fast, like within 5 to 10 years.
And I think that follows up on what Brion was saying about, the actual biology of the meniscus is really, we all spend a lot of time studying this and understanding it. But the key factors are it provides a cushion, right? And it provides some stability. And that stability factor allows people, when you lose that with that root attachment, it does change the kinematics of the knee, and bad things can happen over time. So that's an important thing, and that's sort of why I was, kind of figuring out what do you tell people about. And it's got those two major components. You did a great job on that. Well, I think talking among surgeons, that's like the big misconception, is that we want to operate on everything. And it's really a very small percentage of what we do, or at least of the patients that we see, need surgery. And we spend a lot of time explaining to people why they don't need surgery. So patients come in with MRI reports, and their friend had this and that. And a lot of our job is to explain what these things are and help people understand the difference between a tear here and a tear there, and those are different things.
Just because you have an MRI finding, but you're not experiencing pain, you're not having any limitations to the activities that you like. If you can go out and play tennis every Sunday, you don't. But then they always ask, but what about my meniscus tear? Well, does it hurt? No. Are you able to play tennis? Yes. Well, you don't have to have surgery, but I have a meniscus tear. So it's challenging with patients, certainly with family, and I do find that it's, at least for me, it's more frequent that I'm trying to talk them out of surgery.
Dan, what do you tell them to, after they've had their surgery and they're in this process of rehab, and what do you tell them are the things that you're worried about and that you want to know from them during this process? Because day one, they're in pain and they're swollen, and at a month, they're still not ready to play soccer again yet, and it's processing this time frame. What do you tell them, the things that you're worried about versus the things that you expect and that they can expect during that time?
The timeline's extremely important when they have the injury, and when you go through the injury from the diagnostics, from the MRI, from the X-ray, and then you decide you're going to do surgery, lay out the whole timeline, which is, this is surgery, I'm going to see you back next week, then we're going to take off the steri strips, we're going to go through everything, we're going to start PT at this time, or we're going to be on crutches for this time. So even from the very beginning, once we've decided we're going to do a surgical management, this is what's going to happen here, then we're going to do this. And then to follow them at close enough intervals so that they don't feel like they're left in the wind. So that this happens at 2 weeks, 4 weeks, 6 weeks, this is what you're going to be doing it. So that way they know, oh, gee whiz, here I am. And if there's lots of swelling and it doesn't seem to be going away, this is what we're going to be doing. So if they know what to expect and the plan coming all the way down up to 6 months, then I think that they usually tolerate it probably much better. They've got a better sort of psyche toward it. They've got a more positive outlook, as opposed to they don't kind of know there's not enough communication between the doctor and the patient. And that's always the most difficult thing, which is some folks are more communicative, some folks are less, and the patient's always better knowing what to expect.
Let's talk a little bit now, Brian, about the patella. All right. So we mentioned patellar dislocation is something that we see in these athletes, but the patella, like the kneecap and knee pain in the front of the knee, which we see all day, every day, and almost all of us have it at some point in our lives. So someone has a patellar dislocation, how, they think they've dislocated their knee, and it turns out it's just the kneecap, which is fortunately a far less traumatic injury. How do you start that process for those patients? Is it different?
I think it's very similar. I approach almost every patient the same in the beginning, which is what we've all kind of said is, calming them down, reassuring them, letting them know that this isn't life, limb threatening, or even, amateur athletic career threatening. And then with the patella, usually they're a little happier when you tell them, again, it's not the ACL, it's not the big bear that everyone is afraid of. And then that approach, I'm not thinking surgery from the start, and I'll reiterate that to them that this typically isn't something that requires surgery. A brief period of rest and immobilization followed by physical therapy, whereas, as you mentioned, the therapist will actually be more intimately involved with them than I will, and sort of outline the timeline for them of when to expect that they can get back to participating in sports or recreational activity. That's the typical patient. Someone that is a recurrent dislocator or has recurrent injury to their patella, they may have more injury to the cartilage behind the kneecap. At that point, if they hadn't had before, then I'd be more concerned that it potentially would need surgery because it's been a recurrent injury, and they likely do have some positive findings on the MRI.
So now let's spend some time on the ACL, right? It's a big topic. We all see it. We all do a lot of these operations. And Dan, so you've got this diagnosis, and and then everybody kind of knows, and this is a high school senior who doesn't really plan to play college sports necessarily, but they do want to be able to do recreational activities. They want to be able to get back. So they're going to have their ACL reconstructed. They've decided that that's what the conversation with the family. When do you do it?
So that's a big point that you bring up is their timeline is they aren't going to play college sports, or they are a rising senior, or is this person a junior? Do they need to be in time for this showcase? You talk about the timing of the surgery, because sort of the magic number for return to play is 6 months. And for most of us, some people will go longer, but the magic time is sort of 6 months, with the provision that most of us tell these folks, we're always like, how fast can you get back? Well, gee, it's March, so you can play in September. But the highest time of re-tearing that ACL is in that first year. So in the first 6 months you go back to playing, you got to understand you're going to have to be a little bit careful. You can't exactly go back with complete abandon, because that first 6 months, and now they're starting to focus on when can I return. But back to the man or woman or boy or girl who's not going to play in college, then yeah, you talk about this is when we're going to do it. If they've got full range of motion, not too much swelling, you can do it at any time. So, in the old days, literature used to say, gee whiz, we got to wait 3-4 weeks, otherwise you get something called arthrofibrosis, or a stiff knee. And if you don't wait those 3 or 4 weeks, you're going to get stiff. Well, that's not so true anymore. The newer literature said you can kind of do them almost at any time, as long as they've got a normalized gait, as long as there isn't too much swelling, and they've got a reasonable range of motion. So at that point in time, it's really what works into the schedule for the OR, for the family, and for you. And so then you take it from there and figure out what works best. Some kids will want to get back and just get it done. I want to get it done because I need to get back as soon as possible.
There's not a set timeline. I think we all agree on that, and working with the patient and their family and their schedules is a good option that we have to explain to people. It's not an emergency. And so this patient has now decided that they want to have surgery, and they're going to wait till school's out because it works better for them to not be trying to go to school right after surgery. They got to finish their exams. What do you tell them about an ACL surgery, Brian? And is it different than any other surgeries that you do?
First thing is it's a same-day surgery. So you don't have to spend the night in the hospital. You're not going to be hooked up on a lot of IVs. It's a same-day surgery. I discuss with them the risks of surgery, which are pretty common to most surgeries, certainly arthroscopic surgeries. There's a slight risk of infection, so you're going to get antibiotics in the operating room. My personal preference, I give them a day or two of antibiotics after the surgery as well, anytime I make a big incision. I'm also worried about forming blood clots in the legs anytime they have lower extremity surgery, so I tell them they're going to put them on a full dose aspirin once a day for 2 weeks, and it's important for them to get up, move around, have the muscles squeezing all of the juices back up to the rest of the body to help prevent blood clots from forming. And then the last thing as far as ACL surgery is that, we can repair your ACL, and that's sort of the easy technical part for me, but it's really up to them to put in the effort for physical therapy afterwards, because as we all know, you could do a perfect textbook ACL surgery with, pictures that, rival a Picasso, but if they don't do their home therapy, if they don't work hard with the physical therapist in the therapy office, and they end up with a stiff knee, then they're not going to be happy at all. And they won't be able to return to the recreational activities that they want to participate in.
And that matches up really well with what we know about ACL prevention, right? And we're not going to talk about that much today, but our therapy department does ACL prevention techniques for kids who've had other minor injuries, and we know that therapy can prevent an ACL the first time. It can also prevent you from re-tearing it.
Correct.
By doing all that work. So it's really, they have to do a lot of work if they want to get better.
Absolutely.
And things are always evolving in what we do. So Chris, is there anything different that you do with ACL surgery now than you did when you were training 10 or 15 years ago?
Well, sure. I mean, and it really pretty quickly after I came out, I've been 16 years in practice now, but I switched to, the ACL we learned in residency was what we call, goes through it's a one tunnel ACL called transtibial. So we drill one tunnel and then we drill the other tunnel through that tunnel, but it puts the ACL in a non-anatomic place. And so in the mid 2000s there was a big evolution, and now we moved the tunnels. So now we put the ACL in what we call the anatomic position, and that's probably been the biggest change really in ACL surgery in the last 15, 20, 30 years. And so the outcomes are better now because the ACL is where it's supposed to be, and so that's the big change. And then some of the other changes is, even in the 2000s we used to use more organ donor tissue, even on young athletes, and then some large, scientific studies came out showing inferior outcomes. Previous to that, the studies had been too small to see that difference, and we saw in really big studies with tens of thousands of athletes that the organ donor tissue was vastly inferior to using their own tissue. So those are the two big changes.
And so you've touched on something, and David, so, we're all sort of practicing medicine, right? We're always practicing because we want to get better. Chris mentioned these studies. How much time do you spend keeping up with what's new, the research that goes on? ACL research is one of the most dominant fields within sports medicine research. How much time do you spend, keeping up with what's new and different and changing and being able to counsel patients based on the best current knowledge?
So I think we all spend quite a bit of time keeping up with what's changing. I'd probably spend about 2 hours per week reading different articles and just keeping fresh with what's going on. And things are changing, and sometimes things change back and forth, and I think it's our job to really kind of assimilate all the information, read, talk with different people, different professionals, and decide, is this something that we need to change how we practice? As Chris was saying about the tunnels or different types of graft, or is this something that bears further, warrants further study? So it really does require a lot of keeping up to be able to assess and really do what is best for patients today.
You're going to do this ACL reconstruction for these patients. What decisions do you have to make with them? Where is it? When is it? Anything else that you need patients to say, hey, I'm on the team and I'm part of this process?
So the decision-making process involves several factors. One of the factors that I think people have touched on in this conversation is graft choice. So we've talked a little bit about allograft, which is cadaver graft, and autograft, which is graft from one's own body. So that's an important topic of conversation, and depending on the age of the patient, perhaps how quickly they want to get back to different activities, that can be customized and tailored to each patient. And then within those graft choices, there are different donor sites, places from which the graft is taken, and that's an important thing to discuss, because while a lot of different grafts can do the job and work very well, there are different issues associated with what we call morbidity, or potentially, just when you take graft from somewhere, there can be pain or some issues with weakness or other potential complications. So that's an important part of the conversation. I really find my ACL patients are the ones who I end up spending the most time with, because I feel like there's so many issues to discuss. If you have an associated meniscal tear, how does that impact the postoperative limitations? As Chris said, with a meniscal repair, you're going to have to be non-weight bearing for perhaps about a month or so. Ironically, the bigger, badder kind of ACL tear, well, you can weight bear right away. So some of that is explaining, and sometimes you don't know if you're going to find a meniscal tear or not at the time of surgery. So I think really spending time talking about these various scenarios, not trying to overwhelm the patient, but really informing them about what is in store. And then we've talked about the postoperative rehab and the timeline. So there's a lot to discuss. If you get patients who, 3-4 ACLs in a day and having this conversation, I find that I'm apologizing to a lot of my other patients later in the day about why I'm running late.
So cut us all a little bit of slack if we're spending a lot of time with somebody else and we're running late. For you, remember that if you need that same conversation, that same discussion, we'll give you the time that you need. I just want to ask, is there any other major issues that somebody thinks our patients should know about ACL or knee injuries before they come see us, or things that we can help clarify on their expectations?
I think the one, going back to the different demographics of ACL patients. So going back to that 45-year-old tennis player or someone that injured themselves skiing, if they have an ACL injury, but they have pre-existing arthritis in that knee, then that's a different conversation as opposed to ACL reconstruction and graft choice. Then we transition to the next conversation of knee replacement. So that, I think we've gone from the 18-year-old athlete who doesn't have arthritis, and it's, kind of a straightforward conversation. As David mentioned, is surgery necessary? What are your expectations if you're 45, 50 years old, tear your ACL, but you have arthritis? You probably don't need ACL surgery, not necessarily knee replacement at that point. Or even, I'm pretty sure all of us have seen a 60-year-old with no arthritis that tore their ACL skiing or playing basketball, and then traditionally the way things change as far as ACL surgery. When I started training 20 years ago, 60 years old, ACL, that's a short conversation. You're not getting surgery, whereas now we may be.
Is that because of the literature, or just because you're getting closer to 60 and you want someone to fix yours?
Luckily, not too close to 60, but probably a little bit of both.
The other thing I think is interesting is that, something that is it's not really new, but is the potential to repair it. There is a very small percentage of injured people where the ACL kind of pulled off, but it's still in really good shape, and you could put a couple stitches in and repair it. And so that's another kind of it pops up occasionally, but patients are happy when that happens. Yeah.
I think that's a great point in that, I think maybe we can wrap it up and come back on another night and discuss this stuff more, because what we know now is that things are evolving. We're keeping up at CAO with how we deal with these. We're going to take each patient specifically and we're going to counsel them through the whole process. And as things evolve, we can get back as a group and talk about this again and see where we are in a year, 6 months, or 2 years, and how things change from what we do now.
We hope you enjoyed this episode of On the Go with CAO and invite you to tune in next time. To learn more about our upcoming episodes or to check out our online library of previously broadcast episodes, please visit cfaortho.com/hub. That's /HUB. Or search for On the Go with CAO on your favorite podcast app. Want to help keep others healthy and on the go? Then please share this episode. At CAO, you'll find orthopedic specialists committed to providing patient standard of care. The information contained in the On the Go with CAO podcast is for informational purposes only. It is neither intended as rendering medical advice nor as a substitute for seeking professional medical assistance. No relationship between the Centers for Advanced Orthopaedics and its practitioners may be created through On the Go with CAO. Any individual with specific questions regarding his or her individual health or treatment options should contact the Centers for Advanced Orthopaedics and schedule an appointment with one of its practitioners.